Today we will talk about morbid obesity and how to properly code and document this condition. E66.01, which is the code for morbid obesity, as well as the Z code for a BMI of greater than or equal to 40. Both trigger HCC22. However, just because the Z code for a BMI of 40 or greater triggers HCC22, that doesn't necessarily mean you have supported the diagnosis of morbid obesity. In order to compliantly capture morbid obesity, you must document the diagnosis along with the supporting elements in the impression and plan portions of the progress note. A physician may determine that a patient is morbidly obese with a BMI of 35 or greater when the obesity plus the documented comorbid conditions are clearly linked to the obesity and create a higher risk of mortality and/or decrease the patient's quality of life. And when an aggressive management plan is documented, the following conditions are considered high absolute risk for increased mortality due to obesity: established coronary artery disease or other atherosclerotic diseases, type 2 diabetes, and sleep apnea. A patient is also considered to be at high absolute risk if 3 or more of the following risk factors occur: hypertension, cigarette smoking, high or low LDL cholesterol, impaired fasting glucose, and a family history of early cardiovascular disease. To properly document morbid obesity in a patient with a BMI between 35 and 39.9, you must include the BMI, the comorbid conditions, and other relevant risk factors, and an aggressive treatment plan. Even with a patient that has a BMI of 40 or more, you should always still document the same way. Here's an example of how to document morbid obesity in a patient with a BMI less than 40. As always, remember to thoroughly document and say what you see. Thank you. I'm Dr. Jabawi, and this is your MRA tip of the day.